Before I begin with my speech, I would like to thank the organizing committee for having me in front of such a distinguished audience. So I'm very happy to be here in a brotherly country, Pakistan. I would like to give you some information from the war zone, actually. And Ömer had actually summarized all the studies that DCB is feasible in every lesion. So I would like to make it a little bit exciting, if you will. So I am doing only CTO and complex PCI, and last year I have done more than 500 cases. So my presentation will be based on complex CTO PCI. And the rationale for DCB in CTO PCI, Ömer has summarized it, and I will not go into that detail, so we lack time as well. So the reason why we don't want to put any stent in any lesion is that because of the stent malopposition, the complexity of the lesions, and we have an elderly, frail patient, and we want to reduce the DABT time. That's the reason we don't want to leave anything behind. And the DCB indications are like this, and I will jump into the cases where I can show you something, and there are a lot of questions. I know with DCB, does it really work? Do we have evidence? Do we have angiographic follow-up? And is one DCB better than the other one? Especially, can we use one balloon 2 times, 3 times? Is it feasible? I will give you real examples in my experience, okay? So all the other data you can find everywhere, and you already have read them and you know them, but we need real evidence for that as well. So regarding this was for me a little bit disappointing. I don't care what the guideline is saying, and the new guideline has degraded in-stent restenosis drug-coated balloon from 1A to 2B. So for me, this has nothing, means nothing, because based on these 3 studies, and the middle study shows that there is no difference in ESAR desire study shows that there is no difference between PCI and DEB in 10 years follow-up, and the other 2 studies showing us a moderately better target vascular revascularization at 3 years. Okay, so this is an CTO, an in-stent CTO. You can see the stent there is a metal jacket there, and who would actually put another second stent in this lesion because of a moderately better target vascular revascularization in 3 years? Personally, me not. Okay, so here what we have done, we did IVUS, and after IVUS we prepared the lesion. Of course, cutting balloon, VHNC, long balloon inflations are very important. You can see after Protege NC, I've used this balloon 3 times, and I got a result like this. And the question is, for considering a better target vascular revascularization, if I stented that lesion long and make a double layer stent there, what option had I if I had a restenosis after 2 metal layer stents? Then I have no option. If I have another restenosis in 3 years, I have still all the options on the table. I can go with stenting, I can go with DEB, I can go whatever I want. But if I have a restenosis in a double layer stent, then I'm done. So we have small vessel disease rationale. I skipped that. I will show you some cases what I have done. Here, this was the LAD lesion, and I put a stent towards the diagonal, and the LAD treated with the DEB, and regarded this LAD as a small vessel disease. So we have evidence that it works. And in large vessels, do we have evidence? We have evidence. Am I doing it? Yeah, I am doing it a lot. You can see here there's an LAD osteal lesion, okay? And this patient is 80 years old, female patient, deemed to non-cardiac surgery. So what I have done here, you can see the 270-degree calcium there, and we did IVL first. You can see the cracks are there. And then we went there with a WHNC, it's a scoring balloon, and we went with the 4.520 NC Protege, it's a drug-coated balloon. And with this balloon, you can see that my balloon is extending outside towards into the left main. So the left main is blocked now. If you have a low ejection fraction patient, an elderly patient, frail patient, you cannot put your balloon more than 30 seconds there in the left main inflated. So the other drug-coated balloons, you see that the other drug-coated balloons, you have to put them there at least for 1 minute. So, and there is no other option. You cannot use them two times or thrice. But with this balloon, you can, at the same location, you can inflate it 3 times. And that's what I have done here. And this is the final result. Here you can see I have some kind of dissection there. And the reason was dual antiplatelet therapy. We wanted to stop the dual antiplatelet therapy after 1 month. That was the reason why we have approached this patient with a DEB. So bifurcation is the most lesions that I like the most, and I'm very confident with them. And here you can see this was a very, very difficult CTO case. I had no antegrade feeding, I had no retrograde feeding, but on CT we had viable tissue there, and the patient had symptoms. We had to do something, and everything went lucky for me. And there was no LAD, and after here you can see there is an LAD, a big LAD appeared after ADR, and at the side branch I treated with a drug-coated balloon, and you can see the dissection there. It's a type C-D dissection, but I left it, and this patient will come after 2 months for contrail angiography. And in CTO PCI, Ömer also has mentioned, and I go very fast. I am still doing my own registry, and I have created a sheet in the Progress CTO registry, and we are accumulating our data and putting our cases into this data. The problem is the patient feel well, they don't want to show up for contrail angiography. If a CTO patient is well after drug-coated balloon, that doesn't mean anything. It could have been closed, and the contralateral supply of the vessel may reduce the symptoms and make the patient symptom-free. So we need contrail angiography to be sure that it really works. That was a very complex patient. And in my all CTO patients, I go 100% DCB when I can. And it doesn't matter whether it's complex, it's retrograde, it's ADR, it doesn't matter. I go totally DCB. So this was a very complex retrograde CTO PCI case, and it was an ostial LAD. And I didn't want to put a stent in the left main, so I left it with the Protege NC 3 times because the balloon was encroaching into the left main and blocked the left main. So I didn't want it to make it a 1 minute inflation. And here you can see we have a very, very appealing result here for me. And this was another case. I will, retrograde case, I will go very fast. I did tip in here. And then what we did, what the HNC first, preparing the lesion is very important. It's not about putting the drug into the vessel wall and then hoping for a good result. You have to dissect, at least micro dissection. You have to use scoring balloons, cutting balloons. And then I use the Protege 3 times, 30 millimeter Protege 3 times, and then a 40 to 30 millimeter Protege semi-compliant again. And then you can see the CTO part was treated only with DEB. It looks like better than the proximal part, which has de novo 50% lesion here. And I begged this patient to come for contrail angiography, and he refused several times because he said, I am working on the field, man. Why should I show up for contrail angiography? Because you want it, he said to me. So I missed the contrail angiography in this patient here. So this was a live case. And in this case, we had already 2 metal layers in the LAD. Okay, the LAD lima is not working. And then we have in IVUS, we see 2 metal layers on the ostial to the left main. So what options do we have? We cannot put a third stent there because it's already in-stent restenosis in the anastomosis side, and we have it from the left main to the LAD ostium. So we crossed the lesion. It was a very complex procedure here. I go fast. And then we did Protege. We used 2 Protege. Normally the lesion was 100 millimeter long. You have to use here 9 or 10 balloons. Because of 3 times usage of this balloon, we were able to use 3 balloons and 100 millimeter long CTO instant CTO. And here you can see the end result. It seems not bad, it's okay for me. And this patient agreed to come for control angiography. We are just waiting that he has the time is ready for him to do the 6 months, 9 months results. So, do we have angiographic follow-up? So they said always do 3 times work. I am not sure whether it's working. I am not sure whether it's working in CTO. So I have my own evidence for that. This was a live case to Cairo CTO 1 year ago. And this CTO was tried twice and they left it. And every time with this kind of dissections was a really complex case. Again, retrograde CTO. And then we had proximal catheter dissection there. And here you can see final result. We had to put a stent in the non-CTO part because it was the catheter had dissected, and the CTO part was treated with drug-coated balloon. And after 4 months, you can see how the vessel has grown. Okay, this was paclitaxel protégé 3 times. We used 3 times protégé in this case. So this is another case. It was a rota case actually. What you can see here is calcification. Okay, it's not a stent there. We have poor calcification, 70 years old lady. Okay, and then the patient, we were deemed to have a rota in this case, but during the passage of the wire, we had total blockage of the flow. Then we understand it was really the bridge collateral. So we switched to CTO procedure. We put a pacemaker, and then we did, we crossed the lesion with Hornet 14, and then after wedge balloon and 4.5 to 20 protégé NC. They have also the NC version. I use it in instant restenosis and in calcified lesions. It gives me a better option. And then you can see the final result here. It seems okay. The patient recovered with discharge, and after 2 months, you can see it's still okay. So that means somehow it's working. So, and this was another case here. I go past with the CTO procedure, and this was the CTO part was only treated with DCB. The proximal dissection we had with the catheter was stented, but the distal part was totally DCB. And after 2 months, you can see how the vessel and even the side branch has grown. I go very fast. I am just about to finish, but I want you to show 2 more very excited cases that I have. So here again, you can see proximal dissection, stented, distal CTO part again, and after 1 month follow-up, you can see I have treated this again with 3 times inflation at the distal part. So this is also a very exciting case, very interesting. You can see the diagonal, it was a CTO, and I wanted to avoid the main vessel. Normally you have to stand from the main vessel towards the side branch, but here I left it with this kind of dissection. You can see this is type C dissection outward, and after 8 months you can see how the vessel has grown, and without any complication on the main branch, just depth the diagonal, the CTO, and you can see I don't care whether there's aneurysmatic dilation or something. I have TIMI3 flow, the patient is asymptomatic, and we will see what will happen. And this was an RCA CTO here. I left this with this is very interesting. You can see here the dissection. This is a type D dissection here, type C dissection, type D dissection. It was a CTO. And after 8 months here, you can see how the vessel has grown. It was again 3 times protégé. So I myself is using, because I have also cost issue, okay? So it's not that much expensive balloon, but you can also use it 3 times, and then you actually preserve 2 more drug-coated balloons. And the thing is, if you cannot cross with the other drug-coated balloon, you have to discard the balloon. But this one has a different technology, and you can use it in 2 times, 3 times in different lesions, and you can take it out and then put it again without any drug loss. So I go fast. Again, retrograde CTO snaring with an RG3 here. I go, and this was the end result. It was an instant CTO, and you can see after 10 months how the vessel has grown. Again, 3 times. usage again. So I go, this one is what I want to show you. You can see this was a calcified LAD CTO. Okay, we crossed with Gaia second, and we did 2 times or 3 times, I cannot remember, after vacancy, after preparing the lesion. Okay, you can see this is a failure. I failed in this case. Okay, it was a type B dissection, 65 residual stenosis with TIMI2 flow. This is a failure. Okay, but I leave this failure with a drug-coated balloon, and you will see after about 1 month, you can see how the vessel has grown, has healed. You know, I'm still trying to understand why some cases are working and in some cases it's not working. Okay, nobody knows. Everyone tries to find answers, but the only way is to share our experience and to see what we are doing right and what we are doing wrong. We are still in the phase of understanding the algorithm. So I leave with 50%, 60% dissections, and the algorithm they have created says that you should leave it not under 30%. But there are cases I leave with 30% and I have total occlusion, and there are cases I leave with large dissections and it heals very well. So still we are trying to understand what's happening. So this was a good result. So this is my very last example. So you can see we have LAD CTO, RCA CTO at the same time. And this is after opening the LAD and the RCA CTO, and I will show you after 10 months results. Here we have some aneurysm there, maybe because of long inflation, I don't know. It works, and I avoided a stent going into that instant restenosis again. It was already instant restenosis. Putting a second stent, I don't care, a moderately 3 years better result in terms of target vascular revascularization. If I have a restenosis, putting another stent there, so it doesn't help me. So I don't care what the guideline is saying about instant restenosis at least. So I made the calc. This is my very last example. So I promise you this is my last. So, but it refuses to play. Okay. So this was the CTO, first playing the CTO. This is the result after 10 months on my left screen there. So it works. So it is true. I am showing you only the good results. Okay. Do I have bad results? Of course I have bad results. But at least even I have achieved a 50% good result. That means I have preserved 50% of my patients from putting a stent there. So this is something for me. And the problem here now is I gather only the patients that have symptoms. That I think I have to embark on another strategy to lure the patients, or I should not do the CTO if they not agree with me for the control angiography. I think that would be the solution to give you better information. Thank you very much for your attention.